a lot to cover in a short amount of time today, so I'm going to get started here. And thank you again. I'm really honored, and I really feel privileged to get to talk to you today about something that is very near and dear to my heart and really is my passion, and that is oncology rehab. And especially today, I'm going to try to focus on breast cancer rehabilitation. If you have trouble with the audio or anything, Stephanie, please just interrupt me, okay? So I often refer to oncology rehab as the missing link in the cancer care continuum. And I've said this for many years, and I still include this because we've made lots of progress, but we still have a ways to go. But, you know, as we know, rehab is inherently reactive. So we wait until there's a problem. But with cancer, we really do have to think differently. We should start at the beginning because we know from the time of cancer diagnosis that as individuals go forward through treatment, there will be side effects and sequelae that will happen. And this will negatively impact function. And oncology rehab should start at the time of diagnosis for our patients with cancer. And I hope today to provide you with the information to better understand why this is important and why we should be involved in the patient's care from the time of diagnosis. So this is where rehab should start, and that is at the beginning. So because this is just me, I had to include some learning objectives. But hopefully today, again, we're going to focus on breast cancer rehabilitation, but really talk about some specific side effects and the rehab implications for that, but how we can definitely be involved. So I want to include this because cancer is a complex group of hundreds of distinct diseases with occurrences that really vary by cancer type, age, sex, race, and ethnicity, socioeconomic status. And in 2020, there were 1.8 million people diagnosed with cancer. But I wanted to point out the most common cancer in men is prostate and in women is breast. And that's why we're going to talk about that mostly today. But also this is followed by lung and colorectal cancer. So because of this, breast cancer is one of the most common diagnoses that we will see in the clinic. And for the lifetime probability of developing cancer in men is 1 in 2, and in women is 1 in 3. But if we look at the survival statistics, we see that the survival rate is high. So we'll see a lot of these patients with adverse sequelae from treatment. So you can see how cancer death rates continue to decrease. So the number of survivors continues to increase. So we have these patients with side effects. And because of this, we see cancer as a chronic disease. And chronic diseases are defined broadly as conditions that last a year or more and require ongoing medical attention or limit activities of daily living, or both of those. And so these are diseases such as heart disease and diabetes, but this also includes cancer. And these are the leading causes of not only death, but disability in the United States. And we're going to talk a little bit about some of the causes of morbidity and in this chronic disease, such as chemotherapeutic toxicities, the late effects of radiation therapy, adverse sequelae of surgical interventions as well. So I'm going to try to cover as much of this as I can today in the short amount of time that we have. But also, I want to talk just very briefly about prevention, because this is another role that we play. So can cancer be prevented? Well, some cancers can be caught early and some can be prevented because we look at these preventable risk factors such as smoking and secondhand smoke exposure, being overweight and obesity, excessive alcohol use, exposure to sun and tanning beds, and infectious diseases. And some things we can do are screening and vaccines and healthy choices. But also, if we look at another great chronic disease really is obesity, because over 40% of adults have obesity. And this increases our risk of heart disease. But also, if you look at this, it increases the risk of some cancers, over 13 types, and breast is one of these. So I wanted to point that out as well. So what about genetics? Well, we know that inherited genetic mutations account for only about 5 to 10% of cancers. And in breast, that's 15 to 20%. So really, there's a lot that we can do as far as prevention, because this is only a small portion of those cancers. Very quickly, just to say what is cancer, you might hear the term tumor, neoplasm, malignancy, carcinoma, or cancer. These are often used interchangeably. The most important thing to note, because it will help you understand better the treatment for cancer, is that tumors or neoplasms are abnormal growths of new tissue that serve really no useful purpose, and they may harm the host organism by competing for blood supply and nutrients. And there's lots of different classifications for this, but we definitely won't get into that today. we're going to move on because our main topic is breast cancer rehabilitation. So I just wanted to briefly touch on the statistics again a little bit, that it is the most common cancer diagnosed in women. It may be ductal or lobular, and our lifetime risk is 1 in 8. And this just shows very briefly what normal ductal cells look like, what non-invasive ductal carcinoma cells look like, and what invasive ductal carcinoma cells look like, because they will actually move out through the membrane of the cell. So when you hear those terms, you can understand a little bit about what that is. And going back to our modifiable risk factors, we can educate our patients. That's so important for us to educate our patients about avoiding, smoking and high amounts of alcohol consumption, and leading a healthy lifestyle and maintaining a healthy weight and physical activity. So we'll talk about some of that as we move along. So again, education is so important in this area. So let's talk a little bit about the treatment for breast cancer so that we can understand the rehab implications of the side effects of our treatment. So the treatment is determined based upon the goal of the treatment. Is it curative or is it palliative? And our interventions may include surgery, radiation, chemo, then these other types of interventions like hormone therapies, immunotherapies, anti-angiogenesis therapies. And usually it's a combined treatment that patients with cancer will receive. And the treatment planning considers a lot of different things that we won't get into today, but when you're looking at their history, you may see their stage, their grade, the location. It does depend upon their physical status and their medical history overall. So in talking about one of the treatments for breast cancer, we're going to talk about a few, and surgery is the first one I'm going to talk about. And again, is it curative or palliative intent? So with curative, we really want to remove that complete tumor. And it's important to note that there's not really a standard definition of how wide a clear margin has to be. But given the differences in the growth pattern and utilization of systemic therapies, a margin of 2 millimeters has been found to minimize the local recurrence of risk in women with DCIS. So I wanted to talk a little bit about that with breast cancer. So you can kind of see what it means to get a clear margin is that you remove that full tumor with a margin of healthy tissue around it. And then these patients will often undergo a lymph node dissection. So the lymph node dissection is removal of the regional lymph nodes relative to the location of the tumor. And it may be full or partial lymph node dissection, or it may be a lymph node dissection. So a traditional axillary lymph node dissection usually removes nodes in levels 1 and 2, but maybe into even the third level. But it also includes the removal of tissue within the axillary basin. And so there's a lot of surgical morbidity following axillary lymph node dissection. So that includes the risk of lymphedema, as well as the potential for paresthesias and seromas and arm dysfunction. So with sentinel lymph node biopsy, what they do is use a radio-labeled isotope, inject that dye, and the idea is that the lymphatics drain to the area of the tumor drains to the first sentinel nodes, the first few nodes, and they check those nodes. And then often, if those are negative, then we can spare the other lymph nodes. So you can kind of see in this schematic here, it shows injecting that dye, and it moves to those sentinel lymph nodes. They check those, and if they're negative, then we can spare some of the other axillary lymph nodes. And this reduces secondary morbidities, which we will talk about, lymphedema for sure here in a little bit, but also seromas, range of motion restrictions, even wound healing and functional restrictions. And just very briefly to touch on another treatment for breast cancer and therefore the rehab implications of this, I wanted to mention chemotherapy. So chemotherapy damages the DNA of the cancer cells, and it affects those rapidly dividing cells, because remember I said that cancer cells are very rapidly dividing, and they also serve no functional purpose, so they can kind of take over the surrounding tissues. The idea is to stop that. But that means it also affects the epithelial cells, like the mucous membranes and hair and nails. And so that's why we have some of the acute side effects that we will see. I'm going to move forward through this. So we might have adjuvant therapy, which is administered after surgery, but a lot of times now we will see neoadjuvant therapy that's prior to surgery because they might want to shrink the tumor or maybe even to relieve pain. All right, so here are some of the side effects of chemotherapy. Again, there's acute side effects that happen because of affecting those mucous membranes and those hair cells. But I wanted to point out a few specific side effects because we will, again, talk later about some of the rehab implications of these. Fatigue, cancer-related fatigue, neuropathy, heart damage, and pain. These are some things that specifically we will see in these patients. There's lots of different classes of drugs, but they're usually used in combinations that we call cocktails. And some of those specific drugs that are used for breast cancer, in particular, anthracyclines cause cardiotoxicity. So we might see some heart issues in those patients. Some of the taxane drugs and the cisplatins cause neurotoxicity. So we might see neuropathies, and also then very, very important is balance issues. Some of them will receive hormonal therapy if their breast cancer is hormone positive. So if it's estrogen receptive and progesterone receptive, then they will receive these hormonal therapies. So that brings along with it another list of side effects. If they're premenopausal, most of the time they'll have one of these SERMs, which is tamoxifen. And you can see these side effects here that we need to think about, such as the fatigue, which we can affect, depression, which, exercise and physical therapy can have an effect on. But we need to know about the risk of blood clots and stroke. But the aromatase inhibitors, which are usually given postmenopausal, one of the biggest side effects of those is AI-induced arthralgia, so joint pain. Again, a big rehab implication. Another treatment for breast cancer might include radiation therapy to shrink the tumor, to help destroy remaining cells at the primary site. And usually they will receive external beam radiation given in daily doses. But this can cause radiation fibrosis, so they can have progressive tissue sclerosis and dysfunction. So this adds to their range of motion deficits, the risk of lymphedema, which we'll talk about in a minute, the inflammation that can continue chronically. It's very much shown that these persons will often have inflammation in that area, increased cytokine production in that area years down the road. So this is something that we want to address and treat early so that we can help as that deposition happens. I talked about that already a little bit. So just to briefly summarize a few of the side effects of cancer, treatment for breast cancer, we will do that real quickly because then I want to talk more in depth about a few of those. But pain, fatigue, loss of range of motion, muscle atrophy, loss of strength, and lymphedema, you will probably see all of these in a patient who has undergone treatment for breast cancer. Postural instability, balance deficits, scar tissue adhesions, depression, anxiety, and peripheral neuropathy. And oftentimes these patients are told to accept a new normal. And this is my big soapbox, I say all the time, in that there are so many things that we can help them with. And so oftentimes they've been told, you have to live with this pain or with this tightness, or of course you have difficulty reaching into your closet. You had a mastectomy. And I tell them, no, we can help you return to your previous level of function, if not even better. So they really do need oncology rehab to help them heal as well as possible. And as I said earlier, sometimes that is the missing link. So I want to move on today to talk a little bit about breast cancer related lymphedema. So this is one of the side effects that we just talked about. Excuse me just a moment as I get a drink of water. So there are many risk factors for lymphedema, but I want to mention a few because, again, there are modifiable risk factors where we can be involved, like high body mass index. But there are other non-modifiable risk factors, so we want to deal with those side effects of these things, such as axillary lymph node dissection, regional lymph node radiation, and taxane drugs. So, excuse me just a moment. There we go. My computer is stalling. And I want to focus on the importance of early intervention for physical therapy intervention for lymphedema. I'd really love to cover the anatomy and physiology of the lymphatic system more in depth, as well as the regional drainage sites, but that's another talk entirely. So if you have questions, you can always contact me. And if you're interested in this treatment, I would encourage you to pursue training in this area, because physical therapy treatment for lymphedema really should be provided by a certified lymphedema therapist. And hopefully, if you do not treat lymphedema, but you work in an area where you treat cancer patients, you have someone in your organization who you can refer to. But I believe it's important for us today to highlight the stages of lymphedema, because that's important to the treatment of lymphedema, and also maybe helping you identify if a patient needs to receive treatment for lymphedema. So these are the International Society of Lymphology classifications. So stage 0 is a subclinical stage, often referred to as the latency stage, where the transport capacity of the lymphatic system is reduced, but still able to cope with the normal amount of lymphatic load. So there's no visible swelling, but an example would be a patient who's had lymph nodes removed, but the lymphatic load still hasn't increased above the transport capacity, meaning they don't, again, have that visible swelling. But in stage 1, there's early onset of swelling. So the transport capacity drops below the normal amount of lymphatic load and swelling develops. So that in this stage, the tissue will be soft and pitting, and elevation helps to reduce the swelling. And the swelling usually decreases overnight. And we often refer to this stage 1 as the reversible stage. We would love to see these patients at stage 0, where we know they've had lymph nodes removed and we can teach them what to do to prevent it. But definitely in stage 1, where it is still reversible before we have secondary tissue damage. Because if it progresses to stage 2, there's consistent volume change, there's pitting, elevation rarely reduces the swelling, and we will start to see lymphostatic fibrosis, which is a proliferation of the tissues. So again, as I said, there's little or no pitting and the tissues are hardening. So we may start to see frequent infections even in this stage 2. We sometimes call this spontaneously irreversible, because we can affect the tissue at this stage, but there will already be some permanent tissue damage. But we also refer to this as moderate lymphedema. But in stage 3, the extremity becomes larger and the tissue becomes harder, and skin changes occur, such as papillomas, which are benign skin tumors, deep skin folds. Oftentimes they get fungal infections. And we would refer to this as late stage lymphedema, or again, stage 3 lymphedema. So why is it important to treat lymphedema early? Well, we know that left untreated lymphedema will progress. In stage 1, where we have swelling that resembles edema, if we can treat these individuals before tissue changes occur, this not only reduces or prevents secondary tissue damage, it also reduces the burden on the patient, the healthcare cost, and the time spent in treatment. So in addition, the lymphedema is then not as difficult for the patient to control long-term, since the secondary tissue damage was minimized or prevented. But left untreated, we know that the lymphedema will progress to stage 2. The rate of progression varies greatly among patients due to many factors, but it will progress. And then if untreated, it will progress to stage 3 lymphedema. And most of the time, this could have been prevented if the patient is referred to physical therapy early on. And you can see in this picture, in this upper extremity stage 3 lymphedema, that the patient still did respond to physical therapy with significant reduction in the lymphedema in 4 weeks. If you look at this picture on the left versus the picture on the right. But you can also see the permanent tissue damage. And again, this could have been prevented with treatment. And the upper picture is a lower extremity. This patient had frequent, because of these skin folds, and you can see the papillomas, frequent fungal infections and other problems. So what's the treatment for lymphedema? Well, complete decongestive physiotherapy, which includes MLD, is the most effective conservative treatment in the management of lymphedema. It is non-invasive, and it's designed to decrease and maintain the reduction in swelling. This treatment plan consists of 4 main components: manual lymph drainage, compression bandaging, and/or compression garments, depending upon which stage we begin treatment. Therapeutic exercise, so we'll address their range of motion and strength deficits, or just for gentle range of motion with compression to aid the muscle and joint pump mechanism to reduce lymphedema, and then skin and nail care to prevent infection. So manual lymph drainage is a gentle manual treatment technique that improves the activity of the lymph vessels and reroutes the lymph flow around the blocked areas into more centrally located lymph vessels. The strokes are designed to stretch the walls of the epiphyseal lymph vessels, and this increases their activity moving the fluid in the appropriate direction. And this utilizes anastomoses between lymph node groups. So in the normal state, lymph is drained from individual areas separated by what we call watersheds into regional lymph nodes. But there are anastomoses that connect the lymph territories, and usually only small amounts of lymph flow through these territories. But when we do manual lymph drainage, we begin in the healthy non-edematous territories. This creates a suction because when we stretch the walls of the smooth muscle, it increases the lymph angiomotoricity, which is just a really long word that means it increases the pumping of the smooth muscle lining of the lymph vessels. And this is how it moves fluid along. So the anastomoses then dilate and the lymph is transported from the edematous area into the edema-free areas. And this schematic here is just to show an example of a person who has had axillary lymph nodes removed in the area where we can reroute this. So this is for someone who maybe has had a left, as you can see, left mastectomy and axillary lymph node dissection. We can reroute that fluid to the contralateral axillary lymph nodes and the ipsilateral inguinal lymph nodes, and even into the supraclavicular lymph nodes and more. This is just a few of the areas here. So the decongestion that's achieved by manual lymph drainage is maintained and optimized by compression therapy. And this is because it increases the tissue pressure and it prevents the reaccumulation of lymph fluid. So we use special short stretch bandages at the extremity after every treatment session because these bandages have a high working pressure to activate the muscle pump action, but a low resting pressure. And this is in contrast to long stretch bandages such as ACE bandages, which have a high resting and low working pressure. Then we fit them with compression garments. But, if we see them early, then we might be able to fit them with compression garments right away. We might be able to avoid that previous step that I just showed you with the compression bandaging because they have not yet developed a large volume of fluid and they haven't maybe even developed any fibrotic tissue. So sometimes we can skip that step. Again, another reason for early referral. And of course, exercise is a very important component of CDT, as I will also talk about exercise later as it relates to cancer-related fatigue and just overall health. But with complete decongestive therapy for lymphedema, we do range of motion exercises to help it helps improve the muscle and joint pump mechanism to reduce the lymphedema, but it also increases the effectiveness of the compression therapy. In addition, we, of course, are physical therapists, and so we will prescribe exercises to address any range of motion and strength deficits and to improve functional mobility, because again, that's what we PTs do. Meticulous skin and nail care is very important because infections are common and a serious complication of lymphedema, especially when you saw those pictures of the stage 3. Like I said, that's often they will have fungal infections, but they can also develop cellulitis infections, which is a bacterial infection and requires antibiotics. So it's really imperative that we teach each individual meticulous skin and nail care to help prevent infection. So if they have an infection, we really can't proceed with therapy until it's under control. So it also slows their progress. So the goals of lymphedema treatment are to utilize the remaining lymph vessels and pathways to decongest the swollen body part, the extremity and the trunk quadrant, to eliminate fibrotic tissue and to avoid reaccumulation of lymph fluid. So this helps to prevent and eliminate infections as well. And we want to maintain the normal or near normal size of the extremity. So the goal really is to bring the lymphedema back to the stage of latency. And to summarize, complete decongestive therapy is beneficial at all stages. So remember I said we want to see them as early as possible before they are in stage 2 or 3 where they have secondary tissue damage. However, we can still see them in those stages and they will get better. It just takes longer and it's more difficult. And then it's more difficult to control long term, but also complete decongestive therapy is safe and reliable and non-invasive, and it does show good results in both primary and secondary lymphedema. And we talked about the 4 components that it involves. So I'm going to switch gears real quick and talk about another side effect of treatment for breast cancer, and that is axillary web syndrome. And this is something that you will see commonly if you see patients with breast cancer postoperatively. It's most commonly occurs following breast cancer surgery with axillary lymph node dissection, but it does occur after sentinel lymph node dissection as well. It can also occur in patients with shoulder and axillary pathology like trauma, infection, or melanoma surgery. It's characterized by distinctive palpable cord-like subcutaneous tissue extending from the axilla into the medial arm. And you can kind of see that in this picture and this schematic. The cords often extend into the elbow in the antecubital fossa area. They may even extend as far distal as the wrist and hand, as you can see here, even extending to the base of the thumb. They can extend into the ipsilateral chest wall, and they are visible and palpable. It's a web of tissue that becomes taut with shoulder abduction and therefore more prominent with shoulder abduction. And it's often associated with limited shoulder range of motion due to this fact. And although it's a common sequela after axillary surgery for breast cancer, it really has been poorly described in the medical literature as to the underlying pathophysiology. The pathogenesis really is still unclear, but it has been attributed to lymphovenous injury during axillary surgery or an obstruction due to cancer. And tissue biopsies of the cords have indicated fibrin clots in lymphatic channels. Imaging studies demonstrated that this also is not compatible with a vein or a nerve or fascia. So it really does suggest that these cords are lymphatic in origin. And it's important to know all that because it will help you understand when I talk in a minute about what the treatment is. So even though there's uncertainty regarding a definitive etiology, looking at axillary web syndrome, we found that the disruption of the lymphatic vessels was reported more commonly, but we can't rule out venous involvement as well. The incidence reported is variable due to several factors because the treatment varies. So the type of surgery, the length of follow-up, and really whether or not the axillary web syndrome was actually reported. But estimates of the incidence range from 6 to 86%. So again, that's a very wide range, but these are the reasons why there's that wide range. And it most commonly develops 2 to 8 weeks after surgery, but it can occur months or years later. So you may see this down the road. And when you do, it is more involved and a little more difficult to treat as well. It also can resolve and relapse. And risk factors for axillary web syndrome include axillary lymph node dissection. Lower BMI is actually a risk factor for axillary web syndrome as opposed to lymphedema, where higher BMI is a risk factor. Younger age, positive lymph node status, having more lymph nodes removed due to more tissue disruption, hematomas, and adjunctive chemotherapy and or radiation. Also, patients with cording are at higher risk for breast cancer-related lymphedema. So we should really incorporate this into our breast cancer-related lymphedema risk stratification, assess for it, and treat it. Treatment is definitely indicated. So what is the treatment? Well, physical therapy is recommended as a safe and effective primary treatment for axillary web syndrome. So we use stretching and strengthening exercises, range of motion, and manual techniques to help improve shoulder function, pain, and quality of life in these patients with axillary web syndrome. And MLD has an added benefit of reducing the lymphedema, which can be involved as well with the AWS. Treatment can rapidly reduce the pain. That's the thing with this axillary web syndrome, is that oftentimes they will get immediate relief because when we release the tension on the cords, their range of motion improves immediately, right away within a treatment session. But without treatment, it could cause prolonged shoulder immobility, which leads to secondary problems like altered movement patterns and poor posture, malalignment, muscle imbalances. They might end up with impingement and rotator cuff issues, a frozen shoulder, soft tissue tightness, and even chronic pain. But an effective manual technique that we use to treat axillary web syndrome is skin traction along the cord. So it involves a gentle stretch on the superficial tissue over the cord using the palmar surface of the fingers. We place both hands along the cord and apply the stretch in the opposite direction with our hands. As this releases the tension on the cord, the patient's arm then can be repositioned into further abduction to apply more tension on the cord. So it's really important that we get feedback from the patient throughout the treatment, as the cord may become tight in another area as one area is released. Because as I said, we will see some immediate improvement in range of motion, and then that area should be worked as well. Another technique we might use is cord bending. This is where we apply a perpendicular pressure on the cord with the thumbs while bending the tissue in the opposite direction with the other fingers. And this can be used in the pectoral region as well. And this often works with someone who has a more chronic condition with axillary web syndrome, where they need a little more aggressive technique. As I said, the cords will often release during manual treatment, and sometimes there will be a palpable and even audible pop or snap that can be experienced. When the cord releases, an immediate increase in range of motion is experienced, and it's not painful. But it's important that we, educate patients that this can happen so that it doesn't frighten them when it does happen. But when it does, it's very quick. Their range of motion improves. There's no pain associated with it, and so they tolerate it very well. But it's important to note that these are gentle manual techniques, and they're very effective in helping resolve the cords without being overly aggressive. So that's the manual therapy part of the treatment for axillary Webb syndrome. Also, complete decongestive physiotherapy, including the previous steps that we talked about, manual lymph drainage being one of them, and short stretch compression bandaging being another. This may help the cording if the cording extends into the arm. We also might do myofascial release and scar mobilization as appropriate. We will incorporate those things. Range of motion exercises specific to the location of the cords are given. Stretching using a low load, long duration technique is very effective in releasing the cords as well, and also in improving range of motion after the cords respond to manual therapy. So that's really important for their home exercise program. Postural education is important for these patients as well. And of course, education is important across the board as always to enhance and improve the results that we did obtain in physical therapy and to help prevent the recurrence. Because as I said, this can kind of resolve and relapse as they go along. All right. So just very briefly, in talking about these treatments and early intervention for lymphedema, I just want to transition back a little bit because I want to mention our clinical practice guidelines. The APTA recognizes the increasing value of clinical practice guidelines to direct clinical practice. So the number of PT-related CPGs continues to grow. And this is really exciting for us to have clinical practice guidelines in our area of practice. And the first CPG from the oncology section is on the diagnosis of upper quadrant lymphedema secondary to cancer. Now, this was published in 2017 in the PT journal and co-published in the Rehabilitation Oncology journal. So that, of course, would be available on our Academy's website. It was published both as an executive summary and a full CPG in the Rehab Oncology journal. So you can look at that executive summary, and that's very helpful. But our second CPG was just published in 2020 in our PT journal, and it's related to intervention. And there is an executive summary of it in our Rehabilitation Oncology journal as well. But it's really exciting that we have this clinical practice guideline to give us some solid evidence, because this helps to back up what we're doing. But why is that? What are clinical practice guidelines? Well, clinical practice guidelines are defined as statements that include recommendations intended to optimize patient care that are informed by a systematic review. So these are large systematic reviews of the evidence, and that helps us to assess the benefits and harms of alternative care options. Oops, sorry about that. Here we go. So it gives us recommendations describing the current best practice for a specific condition based upon the best available evidence. And it's defined by stringent methodology. So again, this gives us some evidence to back up what we're doing. It's developed with a specific population in mind. That's important because there's so many variations in patient presentations and comorbidities. So we need to determine from the evaluation and examination process whether the CPG is appropriate for implementation in a specific individual's plan of care. So for example, the diagnosis of upper quadrant lymphedema secondary to cancer really was written specifically on diagnostic tools for patients with upper quadrant lymphedema secondary to cancer. So that includes the upper extremity, head, neck, trunk, and breast. So these recommendations are specific to this population and really shouldn't be generalized to lower extremity or peripheral edema not caused by cancer. And same thing with the intervention CPG. This is based also upon breast cancer-related lymphedema. But as we discussed earlier, when I was referring to the stages of lymphedema, this CPG covers interventions that are necessary at various time points throughout the cancer trajectory, beginning at diagnosis and continuing throughout survivorship. So it gives us evidence-based recommendations that can guide clinical decision-making for selecting appropriate interventions based on an individual's clinical presentation. So how do we implement these into our practice? Well, we can use these to assist our clinical decision making regarding diagnosis and interventions to optimize care. And before we implement these into practice, we really do need to determine whether or not this applies to our patient population. And if therefore it helps us to make sure we're meeting the recommendation and providing the best care. And it gives us an opportunity to facilitate change if we need to. So we can collaborate inter and intra professionally when we need to use the resources that we have to improve care and to promote patient outcomes. But we must always remember that evidence-based practice includes not only the best scientific evidence, but also our clinical experience and expertise and the patient's preference and goals. So as a profession, we need to really research the efficacy of new care options as well and disseminate these findings to move us forward as a profession. So I encourage you to use these newly developed CPGs to review your practice and implement change and move the profession forward. Or for you students as well to look into these as you go through your clinicals or as you are deciding if you do want to specialize. So in talking, let's see, I want to look at our time because I'm trying to cover a lot in a little time, and I want to make sure that we have some time at the end for discussion. I just do want to very briefly talk about, as far as talking about breast cancer rehab, I think we need to recognize the prospective surveillance model. And this is really it was introduced, the idea was introduced in 2012 that we should start at the beginning, at the point of diagnosis, as I've already discussed a lot, because we know that sometimes when patients are diagnosed with cancer, they feel pretty good, pretty normal, and pretty healthy. But the very treatment that's meant to save their life is making them sick. So with prospective surveillance, we can take advantage of the opportunity to identify a baseline status in the healthy person and see them early with screening protocols and therefore implement early rehab immediately postoperatively, or if they do experience any deficits, they will know to contact us, and we want to follow them at intervals throughout the course of their care. And I'm going to, get my mouse to work again here, skip over some of this. So it enables early detection of an intervention for treatment-related impairments. Early intervention will help decrease the severity, as we've talked about, especially with lymphedema and range of motion deficits and tissue damage. And so then we will be able to also help them as they progress through the stages of survivorship. And this is just a schematic that talks about when we would use prospective surveillance. And I am going to skip over that, but you can find that in this article that I just referenced earlier. If anyone wants that, you can email me for that article so that we can move on a little bit. But it helps you to kind of see what types of treatment you'll be providing in what stages along this model. But we would like a baseline if able. We'd like to see them post-operatively. This is, again, talking about breast cancer patients who've undergone a lumpectomy or a mastectomy with either axillary lymph node dissection or sentinel lymph node biopsy. And then we like to see them every 3 months for the first year. When appropriate, we'll switch them to 6 months. But in the beginning, things are changing as they go along this first year, because maybe when you see them back in 3 months, they might just be getting ready to start radiation, or they might have just finished radiation, or they might have just finished chemotherapy. So things are changing. I always talk about the oncology rehabilitation being such a dynamic process, because the way the patient presents to you today may be very different than how they present to you next week as they are going through treatment and they're having different side effects. I always want to refer you to our Academy's website, oncologypt.org, that you can also access the journal there. And there's a lot of good information, including our EDGE documents, which are systematic reviews that provide us with information on the best outcomes measures to use with different types of cancers. I'm going to quickly move on to talk a little bit about cancer-related fatigue, because that will lead into talking about exercise guidelines. And I'll take about probably 5 or so more minutes to talk about those things, so that then we can allow some time for questions. Cancer-related fatigue is really the #1 side effect of cancer and cancer treatment. And it's one of the most common side effects that's not specific to any cancer diagnosis, but rather it impacts up to 96% of survivors at any point along the survivorship continuum. And it's defined as a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer or its treatment that's not proportional to recent activity, and it interferes with usual functioning. So one of the most important considerations, and often one used to assist in the diagnosis of cancer-related fatigue, is that it's not relieved by rest. So this sense of fatigue is perceived not only physically, but also cognitively and emotionally. And sometimes it seems like there's no rhyme or reason to it because it's not relieved by rest. It's reported most consistently in those undergoing chemo, whether in isolation or in conjunction with radiation therapy, but it may persist after treatment and occur in those individuals not receiving those treatments. So, as I said, it's the most common side effect. It affects at least 90% of cancer patients, and 30 to 75% say they feel continued fatigue for months or years after treatment. So many factors contribute to this, but again, this is where we can help. It's important to get to the bottom of some of the causes because it may be due to their medications. It may be due to anemia or sleep disturbances, but oftentimes it's due also to weakness and lack of activity and immobility and pain, and a lot of those things, again, that we can address in physical therapy. So I said that cancer-related fatigue is the number one side effect, chronic side effect of cancer and its treatments. I would say exercise is the number one treatment for this. And we know that moderate to high intensity exercise is safe and effective for most individuals with cancer, that it mitigates the side effects and impact on function, and it may prevent some late effects. It helps reduce fatigue, and it impacts anxiety, mood, and affective domains. So this article was published in Rehabilitation Oncology just in 2019 in an executive summary, but the American College of Sports Medicine convened an international multidisciplinary roundtable on exercise and cancer in March of 2018 to really bring together a group of exercise and rehabilitation professionals representing multiple disciplines, as well as key professional and stakeholder organizations, with the goal to update recommendations based on current evidence around the role of physical activity and exercise in cancer prevention and survivorship. So this is really exciting, again, to look at the evidence behind exercise and its effects on fatigue and also reducing risk of recurrence and survival. So the roundtable participants were charged with reviewing the state of the evidence, and the Academy of Oncologic Physical Therapy of the APTA and the APTA were two of the 19 organizations that supported this roundtable. So they sent a representative to attend. What they found is there's strong evidence for a protective effect of physical activity against colon, breast, endometrial, kidney, bladder, esophageal, and stomach cancer. There's moderate evidence that pre-diagnosis physical activity may reduce risk of dying from cancer, from breast and colon cancer, and moderate evidence that higher levels of physical activity post-diagnosis are associated with lower risk of dying from colon, breast, and prostate cancer. So again, this is really exciting for us because this is where we can educate our patients on exercise guidelines, not only to reduce fatigue, but also to help with survival. And they found in this most recent roundtable that an exercise prescription of moderate intensity aerobic exercise and or resistance exercise at least 3 times a week for 30-minute sessions for at least 8 to 12 weeks help to improve common treatment-related symptoms. So we know that our general guidelines, you all have probably read this in our literature, are that we would really like for patients with cancer throughout survival to engage in at least 150 minutes a week of moderate intensity exercise and 2 days of resistance exercises. But this shows that even 90 minutes a week was beneficial. So we really want to teach our patients to move, right? So again, why exercise? Well, as I've said several times, and as you can see here, that it helps to prevent specific cancers and also lower the risk of dying, that it's also safe for survivors. And also down here in this little print that you can't see, we know that it doesn't increase the risk of lymphedema, but actually helps to reduce exacerbations of lymphedema. So I think I've already said that. So again, just to kind of summarize here, we know that oncology rehab facilitates optimal physical and emotional recovery from cancer and its treatment. And as again, I often refer to it as the missing piece of the cancer care continuum. So we really have to work together with other healthcare professionals as a team to make sure that they're aware that we are available and that physical therapy can help, because we know there are millions of cancer survivors that are suffering from these side effects that we can help with. All right, here is my contact information. I can get that email in the chat if you want, Stephanie, so that if anyone wants to email me, because I know you all don't have a copy of this presentation. If you have any questions, I know I went through a lot of that really fast. There was so much that I wanted to cover, and I always have a hard time of condensing, so I hope I wasn't rambling along too quickly. But now I would like to entertain any questions that you might have. So if it's okay, I'll stop sharing my screen. Whoops. Okay. Oh, there it is.
Oh, perfect. First of all, I just want to thank you so much, Paula. That was a fantastic presentation. And I hope that you all got a lot out of that, as much as I did, at least. And for questions, there actually was one in the chat from Shai to start out. And this dates back to the middle of your presentation about lymphedema. And his question was, do taxanes cause lymphedema or, quote, pseudo lymphedema?
Well, it's just been shown that it increases their risk of lymphedema. So what you might mean, Shai, and hi, Shai, it's great to see you. I think that, and what I tell my patients too, is anything that causes an increased load on the lymphatic system can cause exacerbation. So I don't think, it's not that the taxane drugs cause lymphedema, it's that it might be that, and that's, I think, what you might mean by pseudo lymphedema, which we would just refer to as edema, because lymphedema means, I didn't get into a lot of the physiology, but it means that we actually have a mechanical insufficiency. So with edema, with its general swelling, it's because the system is overloaded. You sprain your ankle or, something like that. Eventually your healthy lymphatic system can accommodate and it can eventually get rid of that. The difference with the mechanical insufficiency is that part of your system is actually not working. So sometimes even a normal amount of lymphatic load can cause lymphedema because you don't have that same capacity. So anything that causes increased swelling, which many chemotherapeutic drugs do because of what it's doing to your body, can then cause an exacerbation of the lymphedema. So I wouldn't call it really pseudo lymphedema. I would just say it's one more factor that contributes to an increased lymphatic load that therefore can cause the lymphedema to either show up, or if you already have it, can cause it to be worse. I hope that helps.
So I do want to open up for everyone to ask questions. Feel free to unmute yourself if you do have any. Otherwise, you can also put them in the chat and I'll read them out like I just did. I do have a question to get us going. So I was curious, I know we didn't go too deep into this, but in regards to radiation therapy, when patients do present with some radiation burns, I'm curious the implications on this that you've seen for manual therapy and kind of what that healing time frame is in regards to your manual treatment.
So the healing time, we know that there's the acute phase and the chronic phase. So in answer to the beginning of your question about where you might see some skin breakdown, some burning, things like that, again, our techniques have improved so much from years ago, and the radiation oncologists are very aware and very careful to watch the skin condition, and often that can be a dose limiting side effect. But when you see those types of acute skin changes, what we do is, as far as it changing our manual therapy, is we don't do the lymph drainage over that area. So because manual lymph drainage is actually a rerouting technique anyway, then we just reroute a little differently. So for example, if we were doing the manual lymph drainage, across across the chest to reroute the fluid away from the involved axillary lymph nodes toward the uninvolved axillary lymph nodes. Instead of starting over on that involved side, we might start at the middle of the chest and just work, that area more. Same as going down to the ipsilateral inguinal lymph nodes. So we absolutely modify our manual therapy when patients are going through radiation. That is a precaution. It's not a contraindication to manual lymph drainage, but it's precaution. So we therefore modify it. You asked about healing times. Were you meaning specific times or just how that affects our treatment throughout?
Yeah, no, I think you answered that perfectly. I just meant generally how it would affect your treatment course. So thank you.
All right. Welcome.
There's another question in the chat. It says, what advice do you have for soon-to-be PT school graduates interested in oncology rehabilitation when starting to think about looking for a first job?
Do it. That's a very, that's kind of a broad question. I'm absolutely want you, we need more therapists in this area. And I will tell you, it is a very rewarding area. And I didn't share much about my background, but I really got into treating cancer patients because I went to the training to learn how to treat lymphedema a long time ago. Stephanie said she wouldn't mention years, but I'll say it was 21 years ago. And so when I started treating those patients with lymphedema, I started then seeing cancer patients. And I always tell people that it not only changed my treatment focus more than I ever realized it would, but it also changed my life because I started to see these patients and see the deficits that they exhibited that were not being addressed. We've made great gains over the past 20 years, especially with the research that has just really, expanded and exploded in exercise, the importance of exercise, but even with the treatment of lymphedema and early intervention, back then we would see them once they had a severe problem. We wouldn't always see them early on where we could prevent a problem. So that's really how I got into this area. So, if you're thinking you want to go into oncology, I would be glad if you would want to email me or call me. I would be glad to put you in contact with many of my colleagues. Scott is on here and he might even want to chime in, but we have residency programs now. So and I know Stephanie, you're aware of a lot of that as well. So as far as looking for your first job, it would be great if you can go to, a large cancer center that has a robust oncology rehab program. But I say that being someone who has always worked in a community-based cancer center, but maybe not one of the larger academic centers, where we have a great cancer center and a robust oncology rehab program. So I would like to talk more in depth with you and kind of see where you think you might want to go, what you're really looking for, even location wise. And I know Scott's on here. I'm going to let him chime in, but I know he would be more than welcome or more than happy to put you in contact with people as well. Sorry, Scott. You knew you wouldn't get off that easy, did you?
That's okay. Anything to support you, Paula.
Thank you.
You know how much I love you. No, just really quickly, because I saw some other questions pop up in the chat there. You're right. I mean, not all of us are going to have the opportunity to, have our first job at a major cancer institution, depending on where you live in the country. So yeah, so whether it's a small community hospital or, even if it's a traditional outpatient physical therapy clinic that's on Main Street, USA somewhere, what I would say is, even if you don't get an oncology specific position starting off right out of school, but it's something that you want to do and you've been doing some research and you've been tuning into these town halls and the career chats and that sort of thing, go to your supervisor and say, when you start that position and say, I want to be the go-to person to see these patients. And so right off the bat, you are identifying yourself, you're showing that initiative, to that company. Again, whether it's a small private practice of 5 therapists or if it's a community hospital, whatever it is, you're showing that initiative that you want those patients. And once you treat that first patient, right? Once you get that first patient with a history of cancer and you treat them and you get them feeling better, that patient goes back to their doctor and says, hey, this PT made me feel better. I can now walk more. I'm now strong enough that I can pick up my grandson and play with him, right? And then that's how it spreads. And then that doctor says, oh, okay, well, now I'm going to start sending more of my patients to this PT. And then your supervisors see that and they say, oh, okay, so we're going to start sending more of our patients with a history of cancer to this person. And then you become the go-to person in that spot. So I think, yes, you don't have to necessarily start off at a major institution. As long as you have that desire and you have that confidence, wherever you start off, you can be that PT.
Thanks, Scott. And also, this question really leads into just a small plug. Within the Student and New Professional Subcommittee, another initiative that we have is something called Career Chats. And so Scott is actually going to be doing one on the 7th, so July 7th at 8 p.m. And all on our social media, there'll be links. But basically, this initiative is so that students and new professionals who are interested in getting into oncology can learn from clinicians already in that field on how they got to this point. So perfect question to field again at that event next week. All right, let's see. So next question is about exercise prescription. And so Michael asks, how much do exercise recommendations shift for patients who are currently battling cancer instead of in that survivorship phase, or even those who are no longer receiving medications in favor of palliative care? Great question.
I love this question because, again, that's another important aspect of oncology rehab is that we are physical therapists, right? So we prescribe exercise, and this is even more reason that these patients need to see us because, as I mentioned earlier, it's such a dynamic process. The cancer care continuum is dynamic. The treatments they're going through, how they're responding, what side effects they're having at different points along the way. This is why we like to see them from diagnosis throughout survival, so we can modify this. So it does shift and it does vary, but most importantly, and Scott and I both say this so often, is you have to meet the patient where they are. You have to start where they are. And I tell my patients that all the time too. We talk about this, wanting 150 minutes of moderate intensity aerobic exercise a week. Well, when you have someone who's been sedentary and they maybe are also very weak and fatigued because of the treatment they're going through, they may not move much at all. So sometimes they have to start with, I tell them, get up every hour or two and walk around your dining room table for 2 minutes, or walk back and forth to the kitchen or the bathroom more often during the day. Make sure you get 5 minutes of continuous activity 3 times a day. It depends on where they are. And then they gradually increase. So you have those patients who are there, who are in active treatment, who maybe are very depleted, or maybe it's too just because they've been sedentary. And then you might have your patient who is an athlete or a triathlete, or, maybe they're wanting to get back to running. And I have patients that run during chemotherapy treatment too, and they do very well, by the way. So that is a great question. And we absolutely vary what our recommendations are throughout. And that's why it's important that we give them an exercise prescription. We get them independent. They go along their way, but then they see us back. So, and especially breast cancer patients with that prospective surveillance model, we're going to be seeing them every 3 months, at least for the first year, if not longer, because they're going to need new compression garments. They're maybe going to need more treatment. Things have changed. So when we see them, we're not just looking at lymphedema. Lymphedema is one part of oncology rehab, but oftentimes that's why we get a breast cancer patient. Then we get to assess their fatigue, their balance. Balance is huge too. That's again a whole nother talk, or 12 talks. But and Scott is an expert on chemo-induced peripheral neuropathy and has done some great talks on that. But and how that affects balance. So there's so many things. And then I pulled up the chat, so I'm looking at the end of your question, the maybe palliative care, same thing. What can we do to improve their quality of life? Even a study several years ago that was looking at, the the fact that patients are not referred to oncology rehab often enough, even though they are reporting functional deficits. Dr. Andrea Chaville, you may have heard of her, has done a lot of research in this area. And she then did a very large study in terminal lung cancer patients and end of life, and showed a great reduction in functional decline, even in those end of life patients, those palliative care patients who underwent, an appropriate exercise program guided by a physical therapist. So we can improve in this. I love your question, like I said, because, we always say from diagnosis through end of life, throughout survival is what we usually say, but even through end of life, we can be involved to improve their quality of life. And that's the lovely thing about oncology rehab.
All right. Thank you, Paula. The next question is going back to lymphedema manual therapy. So it's about regarding manual lymph drainage. You mentioned going from affected to unaffected lymph nodes. Is there a general rule of thumb for the direction? And yeah, she mentioned it's going proximal to distal.
Yes, definitely. So the treatment sequence is very specific. So just to very briefly summarize, we start proximally stimulating the healthy lymphatics, and then we move the fluid from the involved area proximally. And absolutely, once you're working on the limb, so our treatment starts out on the trunk. So proximal to distal might be a little different in that area because it's really from uninvolved to involved, from involved to uninvolved side. So moving toward the healthy lymph nodes and also using the healthy lymphatics. But if you're working on the limb, the arm or the leg, then you're definitely going distal to proximal. You start proximally to clear the area. And then when you're actually doing your lymph drainage to facilitate the movement of the fluid, you're working distal to proximal, and then you rework the proximal areas. So I hope that makes sense. But again, look into a training course for lymphedema, and because if you treat oncology patients, it's so helpful if you also treat lymphedema. But many do not, and so you just work with a team who has a certified lymphedema therapist.
All right. Does anyone have any last questions? I want to respect everyone's time as well as Paula's, but I do want to open this up to make sure that everyone is heard. I have one closing question if no one else does. Paula, you did mention some resources, but I want to ask you specific to breast cancer rehab, and I guess you can include just generally oncology rehab. What resources would you recommend for students and new professionals to look at, following this meeting and moving forward?
So definitely our Academy's website, and you may all be familiar with that anyway, but definitely there are a lot of resources on there, and also just links to resources to give you, information. If you all are, I hope you are a member of the APTA as a student, then you also have access to the Rehabilitation Oncology Journal. So the link is on there. And then you have access to our EDGE documents, like I mentioned, that, have that so many of those are available with lots of recommendations on outcomes measures that are evidence-based. But also just the, constant literature that's coming out that's backing up what we're doing in oncology rehab and showing the improvements that we're making. Also, if you're thinking about specialization, the ABPTS, the American Board of Physical Therapy Specialties site, and you can actually link that from the APTA. So just the APTA site in general, where you can get a lot of information. So I definitely would do that. Reaching out to any of us specialists, because you can, and actually, again, through the website, you could do that, or you could contact me And I could give you information so that if you had specific questions, maybe we could answer those and direct you in the right way, or to others, of our colleagues who we treat different, we do different things. Some of us work in outpatient, some of us work in inpatient. And so we could help direct you to a resource that could answer your questions if we're not able to answer those specifically. Does that help, Stephanie?
Yes, definitely.
What you're thinking? Okay.
Thank you.
Okay.
Well, thank you all for coming tonight. I really appreciate you taking the hour out of your night. And I know it can be late for some of the East Coast people, so thanks for being here. And thank you to Paula so much for taking the time to present tonight and be with us. And I hope that this is just the start for everyone in, starting to explore a bit more about oncology rehab. This just skimmed the surface tonight. As Paul mentioned, it's so hard to squeeze it into 45 minutes. So there's so much more to learn. So thank you so much.